Good morning, everyone. Today we are going to have problem-based learning. Here is a case of 23-year-old male who presented to our hospital with the chief complaints of recurrent episodes of sudden onset of pain upon awakening, associated with redness for 2 months in both eyes. He had no symptoms at the time of presentation. Past history, he was diagnosed to have keratitis in both eyes elsewhere and treated with topical steroids and lubricants. But there was no relief and the symptoms reoccurred. There was no history of any systemic diseases, and there was a strong positive family history. His mother, uncle, and maternal grandfather, all of them had the similar complaints, and they have the blurring of vision in both eyes. So what could be the cause of pain upon awakening? It is due to the corneal erosions, because at night during sleep there will be lack of evaporation of tears, which causes hypotonicity of the tears, resulting in the superficial epithelial edema, and epithelial separation is maximal at night. So during sleep, the surface tension of the tears, it causes adherence between the lid and the cornea. So when the patient opens his eyes, it produces a shearing force which rips off the epithelial cells. That stimulates the nasociliary nerve, which provides a sensory innervation to the cornea, which is responsible for pain. So what is the cause of these corneal erosions? It is due to the abnormal epithelial adhesion to the underlying basal lamina. Hemidesmosomes, collagen and collagen types 4, 7, 12, fibronectin, laminin, and matrix metalloproteinases. They regulate this adhesion network and modulate the wound healing process. The dysfunctional hemidesmosomes, they cause epithelial cells to adhere poorly to the basement membrane and enable the formation of corneal erosions. So what are the conditions that cause these recurrent corneal erosions? Trauma, corneal dystrophies, previous corneal infections, meibomian gland dysfunction, diabetes mellitus, ocular rosacea, band keratopathy, nocturnal lagophthalmos, and dry eye syndrome. The positive family history in this case helps us to understand that it is an inherited disease, and it could be due to corneal dystrophy. And as we know that corneal dystrophy is a group of inherited corneal diseases that are typically bilateral, symmetric, slowly progressive, and not related to environmental or systemic factors. Clinical findings seen in this patient: visual acuity was 6/6 in both eyes. Slit lamp examination revealed corneal haze with linear branching refractile opacities and dot-like opacities in the superficial layer of the cornea, better appreciated on retroillumination in both eyes. Peripheral cornea was clear. There was no epithelial defects. Corneal sensations were normal. Lens was clear. And IOP with Goldman applanation tonometry was 12 mm of edgy in both eyes. Posterior segment was within the normal limits. These are the clinical pictures of his mother. She showed similar corneal opacities in the superficial layer of the cornea. They were refractile linear branching opacities, better appreciated on retroillumination. Based on the young age of the patient with bilateral presentation, symmetric linear branching refractile opacities in the anterior in the superficial layer of the cornea with positive family history, we came to a provisional diagnosis of lattice corneal dystrophy in both eyes. Differential diagnosis. In this case, the important differential diagnosis could be granular corneal dystrophy type 2, Avellino dystrophy, in which we can see the similar picture with both linear opacities and dot-like granular opacities. So how do we differentiate it from lattice corneal dystrophy? The linear dystrophies in Avellino type, they are more white, opaque, and dash-like, while in the lattice corneal dystrophy, they are translucent, refractile. And the deposits in Avellino type, they rarely cross or form the characteristic lattice for which lattice corneal dystrophy was named. Lattice corneal dystrophy, it has to be differentiated from other types of granular dystrophies and macular dystrophy. All of them, they present in the early stage. They can present in the first decade. And inheritance in macular dystrophy, it is autosomal recessive, whereas in lattice and granular dystrophy, they are autosomal dominant. And in macular dystrophy, we can see early reduction of vision in the earlier stages. And erosions are most frequently seen in lattice corneal dystrophy when compared to granular and macular. And opacities in granular dystrophies, they are discrete with clear intervening spaces in the stroma. In macular dystrophies, we can see opacities with intervening hazy stroma. And lattice dystrophy, we can see refractile tiny lines or dots. And corneal thickness is thin in macular, whereas it is normal in both granular and lattice dystrophy. And the material in granular dystrophy is hyaline. In macular dystrophy, glycosaminoglycans, and lattice dystrophy, amyloid. Hyaline in granular dystrophy stained with Masson chrome, and in macular dystrophy, glycosaminoglycans, it stains with Alcian blue, and amyloid with Congo red. And the distinguishing feature in granular dystrophy is clear limbal zone. In macular dystrophy, opacities reach up to the limbus, and cornea is thin. And in lattice, we can see lattice lines. These are the pictures of different types of dystrophies. So what investigations can we advise in this patient? Optical anterior segment OCT to know which layer of the cornea is involved and what do we expect to find in the report. There can be atrophic epithelium, disruption of the Bowman's layer, inclusion extending from the Bowman's layer into the anterior stroma, and confocal microscopy we can do to know the patterns of the deposits in the cornea. It shows linear branching structures in the stroma with changing reflectivity and poor demarcated margins. In this patient, we went ahead with anterior segment swept source OCT in both eyes. This is the anterior segment OCT report of the patient, swept source OCT, showing radial scan of 6 into 6 mm. We can see in the superficial layer of the stroma, there are some opacities. This is the anterior segment OCT report of his mother. His mother had more dense opacity, so we can clearly see here there is disruption of Bowman's membrane and deposits in the anterior stromal layers. And the corneal thickness is normal. We came to a final diagnosis of lattice corneal dystrophy in both eyes. Lattice corneal dystrophy, it is an inherited disorder of the eye characterized by the deposition of the amyloid resulting in progressive loss of vision. There are 4 types of lattice corneal dystrophies. The first type is classic type. It is also called Bieber-Hab dimmer. And the type 2 is lattice-like dystrophy. It is not a true corneal dystrophy. It is also called familial amyloidosis. And there are other types like type 3 and type 4. Type 1 is an autosomal dominant with mutation in the transforming growth factor beta induced gene, and it often presents at first decade. There are subepithelial fine refractile branch lines or dots, and they progress from center to periphery, and Descemet membranes and membrane and endothelium is not involved. Type 2 is also an autosomal dominant. It is due to the mutation in gelsolin GSN gene, and it presents in third to fourth decade, and it spreads from periphery to central. These are the different types of lattice dystrophies. Type 3, we can see thick midstromal lattice lines that extend from limbus to limbus, and it present in older age. And type 4, they are deep, large nodular lattice lines that progress from posterior to anterior, unlike the other types that progress from anterior to posterior. What is the pathogenesis behind these deposits in the cornea? The accumulation of mutant form of the transforming growth factor beta induced protein. It is also called keratoepithelium. It is a mutant TGF beta protein. So it is the product of TGF beta gene protein that accumulates in the anterior part of the cornea. Histopathology in lattice corneal dystrophy type 1 shows multiple eosinophilic amyloid deposit in the anterior part of the stroma between the Bowman's layer and anterior stroma, and it stains with Congo red. Electron microscopy shows and fusiform deposits, and polarization microscopy shows bifringens. And lattice pattern of this deposits are due to this amyloid filaments that are highly aligned with a diameter of 8 to 10 nanometer. What is the clinical significance of these corneal deposits? Amyloid deposits are responsible for recurrent corneal erosions and corneal opacification. And the definitive treatment is penetrating keratoplasty, DALK, phototherapeutic keratectomy, femtosecond laser lamellar keratoplasty, femtosecond assisted anterior lamellar keratoplasty, and it has a good prognosis. Signs of lattice corneal dystrophy not seen in this patient. This patient had 6x6 vision, normal vision. This visual impairment was not present in this patient. If it is present, what does it indicate? It indicates that there is a progressive loss of vision due to corneal opacification, and it requires phototherapeutic keratectomy or lamellar keratoplasty or penetrating keratoplasty. What are the management options do we have to treat lattice corneal dystrophy? So in the initial stages, conservative treatment can be given, like lubricants, bandage, contact lens, hyperosmotic agents, corneal scraping, or stromal puncture. And in the late stages, if the visual impairment is present, we can go for full thickness keratoplasty or lamellar keratoplasty. In this patient, conservative treatment was given as the vision was relatively good. Newer therapy like gene therapies are also under development and may soon be the mainstay of treatment for corneal dystrophies. Prognosis is good with surgical intervention, but recurrence due to continued amyloid invasion of the grafted tissue require further or repeated treatment. So this study has shown that recurrence rate was found to be 5% at 1 year, 26% at 8 years, and 56% at 15 years following keratoplasty. And the median survival period for recurrence was 15 years. And recurrence was found in 20% of penetrating keratoplasty and 14.3% of DAL cases. And the outcomes of graft are similar following penetrating keratoplasty and DALK, but DALK appears to provide better visual outcomes when compared to penetrating keratoplasty. Patient counseling. We have explained the patient that this condition is an inherited disorder because as there is a positive family history. In early stages, it can be treated with conservative measures like lubricants, bandage, contact lens, use of hyperosmotic agents at bedtime. If recurrence of symptoms occur, if it is really annoying, then we can go for corneal scraping, diamond burr polishing, topical antibiotic use, antiostromal punctures. If there is reduced vision and conservative measures doesn't provide symptomatic relief, then lamellar or penetrating keratoplasty can be performed. Regular follow-up is necessary for appropriate management, and genetic counseling and testing may be helpful in diagnosis and family planning. Thank you. Avellino lattice lines. Avellino. Abrasions. Abrasions. Superficial abrasion. Folds. DM folds. DM folds. Corneal nerves. Corneal nerves. Yes, ma'am. Keratoconus. Keratoconus. Okay. Mucopolysac. Mucopolysac. Ask.
To present a case, which is improving. IOP measured with Goldman applanation tonometer in right eye is 14 milli. Foveal reflex is present. In left eye, media clear, optic disc and vessels are normal. And fovea. This laser is delivered through coming to fundus. Most probably the clinical diagnosis is sub laser posterior hyalodotomy, uh, laser NDR laser, Fundus examination showed premacular boat-shaped and asked him to come for follow-up after 1 week. Yeah. Location of the hemorrhage. To know the location. Hmm. Yes, sir. Yes, sir. Retinopathy and trauma, macroaneurysm, retinal macroaneurysm, it usually occurs in an otherwise healthy eye and spontaneously resolves. It occurs after an increase in intrathoracic or intra-abdominal pressure due to activities such as coughing, vomiting, lifting, straining for a bowel movement, strenuous exertion, sexual intercourse, causes subsequent rupture of small superficial capillaries at the macula, which results in unilateral or bilateral hemorrhages. Clinical features: sudden painless decrease in vision or scotoma after Valsalva maneuver. Fundus examination reveals a pre-retinal hemorrhage located in the premacular area below the internal limiting membrane, but may show break through the subhyaloid or intravitreal space. Double ring sign can be seen, which is characterized by separate margins of subhyaloid hemorrhage peripherally, that is outer ring, and the inner ring is sub-ILM hemorrhage. So this is the double ring sign. Investigations can be done in this case are optical coherence tomography to determine the location of the hemorrhage, whether it is subhyaloid or sub-ILM. Retinal fluorescent angiography is used to rule out neovascularization or any active leakage if it is suspected. Lab tests are performed to rule out pathologies like diabetes, sickle cell disease, or other blood dyscrasias like leukemia. Management is observation. If hemorrhage is small, observation or of spontaneous resolution can be done. Advise patients to avoid anticoagulant drugs and strenuous physical activity. NDR laser Sir, underlying causes. Underlying causes like energy. Yes. After yaga. Yes, before. Blood. Okay.